Hello, my name is Professor Mark Taubert. I'm a palliative care consultant in Cardiff. I also chair the All Wales Advanced and Future Care Planning Strategy Group. And in this video today, I was hoping to give a little update on what version 5 of the All Wales DNACPR policy holds and what changes we have made. It's fair to say that it's taken us most of 2024 to update the policy. This has in part been due to waiting for reports, for instance, from Health Inspectorate Wales and other groups that have been reporting on the often hot topic of DNACPR. And we've had an eagle eye on those. Now, I recommend that everyone reads the All Wales DNACPR policy. Today in this video, I'll go through it a little bit and give you key updates. But of course, that's not a complete replacement for reading the policy itself and looking at the new version of the All Wales DNACPR form itself as well. So several reviews of DNACPR processes across Wales have taken place in recent years, including a detailed Health Inspectorate Wales review, National Mortality Review Group thematic DNACPR review, and the National Nosocomial COVID-19 Programme for Wales. Back in 2023, all health boards and trusts in Wales took part in a thematic review on DNACPR initiated by the NHS Wales Executive Performance and Assurance Quality and Safety Division in conjunction with the All Wales Mortality Review. Each local health board has adopted the national DNACPR policy that's been in place since 2015 and therefore has to ensure that there's a rolling program of audits and reviews for DNACPR and advanced and future care planning practice at a minimum of every 2 years. And this is usually led by the local resuscitation officer leads. Any outcomes, challenges, and action plans are then presented to local health board, trust, quality and safety boards, or equivalent clinical governance organizational oversight structure, and also staff involved in order to swiftly address findings. So the thematic reviews concluded the need for ongoing focused education, highlighting the many existing education resources, including ESR that we have developed on DNACPR and the All Wales DNACPR form. And these have been disseminated to all health boards and trusts. This also aligns with the reviews from the Older People's Commissioner for Wales, who kindly also published education resources on DNACPR, which you can find on their website. All this is echoed in the National Review Report on DNACPR by Health Inspectorate Wales from 2024. They scrutinized practice, they scrutinized forms, documentation, and also reviewed each health board and trust's last 3 DNACPR audit submissions over the last 8 years. Health Inspectorate Wales also surveyed the wider public and clinicians and concluded that consideration for individuals' needs, values, belief, culture, religion was an important part of the process, but also could form part of quality assurance and audit processes. Such information on, say, cultural or religious aspects of DNACPR, for instance, some cultures erroneously conflate DNACPR with euthanasia, which is forbidden in religions like Islam, should be more readily accessible and can be considered by all clinicians involved in a person's care. The All Wales Advanced and Future Care Planning Group, which I chair, have made many resources available, including information about DNACPR decisions for people of Muslim faith. And we've worked closely with Muslim Doctors Cymru, who also sit on our group and are represented to improve this dissemination. These resources can be found on wales.nhs.uk/DNACPR, and I've provided a little link there in the background. A Hospice UK report called I Just Want to Be Me, Trans and Gender Diverse Communities Access to and experience of palliative and end-of-life care highlighted some fears of discrimination when it came to advanced care planning, future care planning, end-of-life care, and DNACPR processes. We've provided some references and education resources, including a Talk CPR video, which highlights these areas and encourages further awareness. And these can be found on the Compassionate Cymru website, including a video with myself talking about the authors of the Trans and Gender Diverse Communities report. We also recorded a podcast with patient carer representatives, including the Bereaved Families for Justice Cymru COVID-19 Inquiry Group, which can be found as a Talk CPR resource, a Talk CPR podcast, talking to the Bereaved Families for Justice Cymru and patient representatives about DNACPR decisions and when things can go wrong as well. The link is in section 10.1.4 of the DNACPR policy, if you would like to listen to that. We've also provided learning resources on wales.nhs.uk/DNACPR with regard to learning disabilities and how important it is not to discriminate and prejudge. The DNACPR policy covers people who have life-limiting palliative illness, where end-of-life discussions may be required, such as in advanced cancer. And we talk specifically in that about NAD, which is NAAD, which is a natural, anticipated, and accepted death that may be lying in the forthcoming weeks to months. Diagnoses such as autism or learning difficulties should therefore never be listed in the clinical summary of conditions and reasons why CPR would not be successful, because they have nothing to do with a natural, accepted, and anticipated death in the coming months. A helpful video can be found in our learning resource section on this, where I talk at the Palliative Care for People with Learning Disabilities conference about DNACPR and take questions from people with learning disabilities at that event. So I thought I'd maybe run through the new policy and share my screen now, just to kind of talk through the different aspects of what we're talking about. Let's see if I can share this. I hope you can see this now as a sort of Word document. So I'm going to go right to the top. So this is the sharing and involving clinical policy for do not attempt cardiopulmonary resuscitation for adults 18 plus in Wales. I'll start with sort of section 1 of this document, sort of the introduction and objectives, which cover a number of areas, but perhaps in terms of the newer version of this for 2024, we reiterate that CPR effectively starts at the point of death, and that a DNACPR, in essence, only becomes active at the start point of death. And I think that's important to mention, because I think we focus on some of the misinterpretation of DNACPR forms that has taken place in the past, that these forms equate to do not care forms, which of course is not true. It just focuses on one particularly unsuccessful aspect of care for people with palliative and terminal conditions, which is CPR, a brutal procedure which often leads to no outcome or no improvement for the person, but can be very traumatic and leave people with significant injuries, and often is unsuccessful. So we focused on this area and have stated that do not care aspects or sort of any allusion that do not attempt cardiopulmonary resuscitation forms equate to lack of aspect to any other form of care is completely unacceptable. So we only focus with these forms on the absence of future CPR attempts in specific circumstances. The policy is more explicit on the damage and dangers of giving CPR to people who are living with frailty and who have palliative illnesses. Section 1 also focuses on clinicians' duty to consult with patients, and we have made that even clearer than in previous policies, and we've made that clearer on the DNACPR form itself. We've updated education links, including national teaching modules and resources with regard to DNACPR, and we've updated on mental capacity. And this has happened in close consultation with the Welsh Mental Capacity Forum and also with kind input from barrister and KC Alex Ruck-Keane, who's been very helpful on developing the All Wales DNACPR policy and aspects, legal aspects of it. The form and policy discuss the ability or inability to engage in discussions about treatment escalation planning, including DNACPR, when it comes to people who may have diminished or absent mental capacity with regard to the ability of doing so. That is sort of covered by sort of section 1 of the All Wales DNACPR policy, which you can read. We then come to sort of point 2, and I wanted to focus again on mental capacity in 2.5. So focus in the policy is on ability of someone to participate in discussions about a specific decision, in this case, treatment escalation planning and DNACPR. And what capacity is, where capacity is in doubt, the right to support in reaching understanding as well. So if you doubt someone may have capacity, then be very sure that you have supported them sufficiently in reaching understanding. So that can be as simple as making sure that their hearing aid is working when you're having a conversation with them. Absent hearing does not equate to absent capacity with regard to this decision. And so that is an important aspect of the policy. We've updated further information about lasting power of attorney, including need to look for information whether an LPA document donates the power to make decisions about life-sustaining treatment, for instance. So we've added that into the section 2.8 on lasting power of attorney. And we've talked about other aspects as well. So for instance, we've talked about the fact that learning disabilities alone must never be used as a reason to put forward a do not attempt CPR conversation. We've added that in section 4.3 of the form when it comes to DNACPR discussion, openness with confidentiality, partnership, and no discrimination. This has been clear in our previous policy versions, but we repeat this again. Equally, it is also unacceptable to treat a palliative patient with a learning difficulty differently to other palliative care patients and to withhold such conversations about good end-of-life care planning from them. So that is another important aspect. It's come to my attention that in parts of the United Kingdom, because of the controversies with regard to learning disabilities during the COVID pandemic, that people are no longer holding advanced care planning, future care planning discussions with individuals who also have a terminal illness or a palliative illness. And that again is as a sort of reverse form of discrimination, which we can't allow to happen. Section 4.4 talks about DNACPR discussions and communication with those close to the patient. And we reiterate the importance of offering that a person close to the individual that you talk to is present during the consultation. And I think that's often very, very important. And communication styles to set up these conversations can be quite a challenge. So if you're talking to a patient and saying, look, I'm going to have a very important conversation with you about the future and what decisions we make, but I would like someone from your family or someone close to you to be present. Is that okay? That can be a way of addressing that issue. And we've given some examples of how you might want to broach such conversations as well. 4.5 talks about documentation of DNACPR discussions and links to other all Wales agreed documents, for instance, to document advanced and future care planning decisions. If you go to the wales.nhs.uk/AFCP website, that has a lot of our future care planning documents on it. So DNACPR forms are not the only form. Parts of England have an agreed advanced care plan form, which is the RESPECT form. And RESPECT is not a DNACPR form. Resource UK stresses it as an advanced care planning form. And Wales for many years has had the ACPA form, which you can find on this site, which specifies other treatment decisions apart from merely CPR and DNACPR. So if you're interested, you could take a look at that as well, and we've provided some learning resources as well. Then we come to sort of section 5.3, where there have been a few updates. So if I scroll down a little bit, then we consider not just discussing CPR and DNACPR, but also other care interventions as part of a wider conversation. So how a DNACPR discussion should be conducted. I mean, I tend not to go into DNACPR discussions by just saying, I want to discuss CPR and DNACPR now. I sometimes use the treatment ladder approach and talk people through their views on all sorts of interventions that may be forthcoming in the coming weeks, months, or years, and find out what the individual who's in front of me, how they view such things. I have some patients who like to be very interventional and would like everything on the cards and on the menu, and others who look at me in horror when I suggest that an admission to accident and emergency for a pneumonia, for instance, could be an idea in order to give intravenous antibiotics. And they say, no, that's absolutely not something I would want. So everyone is different. And I think if you use the treatment ladder approach, which is on our talkcpr.wales resource site, that can be a useful way of not just talking about CPR and DNACPR, but about other aspects of care as well. We've also in here introduced terms such as those close to the patient and chosen family, which is when we've been listening to our patient and carer representative groups who sit on the Advanced and Future Care Planning Strategy group for Wales, is a preferred term, especially because some people have non-blood relatives who they've made their nominated next of kin. Everyone is different. Every circumstance, every individual is different in terms of who they nominate and who they want to be in charge if they are unable to communicate themselves. Section 5.4, DNACPR mental capacity, again, very important. And we update regularly with various mental capacity forums, both UK-wide and nationally within Wales. But there's some more information here on the recording of mental capacity and where this is in doubt with regard to DNACPR discussions. And that recording of such information does not, according to the Code of Practice, have to be on pre-specified forms from each health board, but each situation will require careful evaluation on how and what is recorded and where. Different health boards may have specific forms that they quite like to record mental capacity and specific decisions, but that is not always necessary. And certainly the law, mental capacity law in England and Wales, does not specify any specific forms. It just asks for evidence that someone may lack at that moment in time the mental capacity to make a decision about CPR, DNACPR, or treatment escalation planning. And how you document that in the contemporaneous notes will be quite important for future review as evidence that that person indeed didn't have the capacity to engage in that decision. Section 5.4 also links to our nationally agreed future care plan form, which records a best interests decision to inform future scenarios. So when someone really doesn't have the mental capacity and engage in such conversations, you can record on this form of best interests decisions, which you've maybe reached with family members or chosen family or those close to the patient, in terms of eliciting the views or future wishes of that individual, which can really inform future decision making. And we've reiterated also the concept of a natural, anticipated, and accepted death, NAAD, which you can read about in this form as a trigger for DNACPR conversations. Again, a very important aspect of this work. And there you have it, 5.52 NAAD, natural, anticipated, and accepted death as a specific trigger. Also to mention that some people have questioned me whether DNACPR forms have some sort of expiry date. The answer is no, it still forms part of the medical record of an individual patient. Some DNACPR forms may even be 2 to 3 years old and have stayed with the patient, but the clinical information on it is still pertinent and valid and should be read. We've put an explanation in the top left corner of the form, which I'll show you a little bit later, that usually DNACPR forms are valid until the end of life, unless specified otherwise. So there might be sort of a temporary DNACPR decision during a period of severe illness where someone is sick enough to die and CPR would not work or not be indicated. However, sometimes people make a recovery from that severe illness, and such as a very severe pneumonia or blood sepsis, for instance, and then a DNACPR decision can be reviewed and looked at again. And in section 5.6 of the form, we've talked about who should have the DNACPR discussion with the patient. And we've added information on who holds these discussions, including nurses and allied healthcare professionals who routinely work in palliative and end-of-life care settings, who have huge experience sometimes. In the past, when this was merely doctors who held these conversations, there were many missed opportunities. A patient would, for instance, sometimes say to a nurse, look, I don't want this done and I don't want this done in future, but please sign me up for these different things. And the nurse would say, sorry, I'll have to shut you down from this conversation because I'm not allowed to hold DNACPR discussions. I'll have to get the doctor. And then by the time the doctor arrived, the patient may not have been willing to further discuss it, or the moment was lost in a sense. So we felt that it was important that the multi-professional team is involved in these decisions, that opportunities are used to pick these sorts of things up, and then to discuss as a multi-professional team as well, that a patient has expressed, for instance, a specific wish. Equally a note in the policy to state that this does not mean that all nurses and all allied healthcare professionals should be expected to hold such discussions. It is mainly for people who work specifically in settings, in palliative care settings or settings that deal with the end of life. So, for instance, an experienced occupational therapist, for instance, who talks to patients in palliative care settings in the hospice setting all the time, may have a very good idea about talking about DNACPR, for instance, and be able to give the patient the pertinent information and then feed it back to the wider multi-professional team as well. So that's what this section covers to some degree. Also information on professionals and the new competency framework that we've developed since the last policy update for clinicians holding DNACPR conversations, which can be found on the All Wales DNACPR website. So you can find a segment on the All Wales competency framework, but also how we got there, sort of the different workshops and discussions and the engagement activities that we held to to develop this framework, this competency framework, and the education sources that are linked to them as well. 5.6 also holds information on who signs Section 5 and Section 6 of the form, including that consultant nurses and consultant allied healthcare professionals who have senior responsible clinician roles can now opt into holding conversations and signing DNACPR forms as well. There's also information on remote sign-offs. For instance, when a senior responsible clinician is not on site, but has been consulted. So imagine a junior doctor has had a long conversation with a patient and their family, for instance, and has written the first segment of the DNACPR form, and then phones the consultant and tells them all about the conversation and what has been said. And the consultant says, yes, I completely agree with this approach. I think it's the right thing to do. Please sign off on my behalf in Section 6, and please add my GMC number into box 6, which is 547413 or whatever the number may be, as a way of remote signing off as well. As of 2024, the BMA published a scope of practice for physician associates, which has stated that they cannot write and sign off DNACPR forms or hold such conversations. So thus far, we have in the policy not stated that physician associates or physician assistants or this group of practitioners can ever sign off DNACPR forms at present. In the past, the DNACPR policy stated that only people with GMC or NMC or HCPC numbers can sign off the DNACPR form. And until now, physician associates, for instance, did not have a GMC number. That may change at the end of 2024. However, at present, given the British Medical Association's stance on their scope of practice, forbidding this from happening, we cannot go ahead and say that they can do this. So that is an area that we will continue to monitor and update on within the AFCP group. Senior responsible clinicians who are not consultants in medicine or GPs, as was traditionally the case for sign-off of the Section 6 of the form, should ideally seek written confirmation from the health board or trust whether they can appropriately fulfill some of the oversight duties that come with DNACPR decision-making. As this will likely on occasion be required, including working with coroners, for instance, medical examiners officers, and writing reports for courts of law. So anyone who is a senior responsible clinician in an organization, for instance, there are consultant physios, consultant OTs who have oversight over certain wards or certain standalone units, for instance, who may have the competency to hold DNACPR discussions and sign off Section 6, should seek confirmation from the health board and be comfortable in the competency framework as is published on the wales.nhs.uk/DNACPR website, but also consider the additional responsibilities that come with signing off such forms and holding such conversations. Yeah, so a little bit of information there on senior oversight of DNACPR decision-making. And then we come to the All Wales DNACPR form itself. And we've added detail here that all segments should be filled in. I mean, that was always the case, but we've perhaps made it a bit more explicit on the form that you must fill in the free text sections and reference capacity assessments, for instance, and where to find them in the patient's records. And please make the capacity assessment specific to the understanding of discussions about treatment escalation and DNACPR. Also make sure that those close to the patient are involved if a person does not have capacity in order to fulfill your duty to consult about these forms. In section 6.4, we've added some aspects around data capture, language, and communication of DNACPR decisions. Some information about dissemination of a decision, including using the ACP flag, the Advanced Care Planning flag, on Welsh Clinical Portal is useful, so to indicate where discussions have taken place. And you can also add more qualitative information if you wish to do so, and look for more qualitative information as well around end-of-life care preferences that can be found on the patient preferences form on Welsh Clinical Portal, which can help clinicians who do not know the individual particularly well to inform their future care planning for an individual patient as well. Reviews of DNACPR decisions are always very important. There was a recommendation from the nosocomial COVID-19 program for Wales that suggested better review processes of DNACPR. Some of our patients, when they have had a DNACPR in place, have expressed frustration at having repeat discussions all of the time about it every time they go into hospital or hospice. So to balance these, slightly divergent kind of ideas and views, we have indicated now on the top left of the All Wales form that DNACPR forms are generally in place until the end of life, unless a specific review date is put in place for a shorter term DNACPR decision. Of course, a DNACPR decision can be reviewed at any point. Say a patient requests this or another clinician requests this, then an urgent DNACPR review can be take place. DNACPRs therefore do not have a specific date at which point they are not valid, as I've specified before, and unless this is specified on a form or review is requested. So some more information also in section 7.3 on how to cancel a DNACPR decision and some of the details of that. And we've expanded the segment on cancelling DNACPR decisions, including what to do if forms have been uploaded to patients' electronic records. For instance, you've got this section here that talks about that. In section 8.2, unpredictable, unforeseen, and irreversible clinical events, we've talked about the situations when the medical condition or medical conditions written on the DNACPR form in section 2 of the DNACPR form are not the cause of the sudden deterioration. As an example, a paramedic might arrive in a situation where there is a patient who, yes, has a very advanced lung cancer and yes, who holds a DNACPR form, but perhaps they've electrocuted themselves in the bath whilst using a hairdryer, or someone's throat is swollen up due to exposure to peanuts and they're suffering a respiratory arrest. And in that situation, the DNACPR form is largely irrelevant because, it's important to then give first aid and to help that person to try and reverse the causative issue. Even if it is a sort of respiratory arrest in those situations, it doesn't cover the conditions specifically written down on the DNACPR form in section 2. And so that area covers those perhaps unusual circumstances. But we looked at specifically at a case in England, in Eastbourne, where an ambulance had not been deployed to a nursing home when a patient there had choked on their breakfast, and they had a DNACPR form in place, but for a completely different set of conditions, and so that was completely unacceptable and led to a big news story at the time. And of course, that cannot happen. So section 8.3 also talks about reviews of DNACPR forms and discussions, and that audit, mortality reviews, quality and safety governance meetings at health board level, DATIX reports and significant event meetings should be used to data collect and learn from the individual situations that occur. And I'd also include in that sort of complaint or concerns meetings, for instance, when a family maybe express concerns around the communication of a DNACPR discussion. And that can take two formats. Usually, often families will raise valid concerns if they feel they haven't been consulted adequately, or they may raise concerns that they find the whole process of a DNACPR discussion quite undignified, and they feel it is not correct to do so. Of course, we acknowledge all this, and communication can be less than adequate sometimes. So we've put out lots of communication resources on how to hold better conversations around the end of life and in the future as well. But acknowledging that these are always very sensitive discussions, and some people really do not like discussing death, dying, bereavement, end-of-life care, and palliative care in general. And we have to be sensitive to that. It's very important. Section 8.4 specifies what to do in situation where there's an implantable cardiac defibrillator, and what the Wales Cardiac Network suggests is done. And in section 8.4, we have written a little bit about the cross-boundary issues. So this has been part of all our DNACPR policies in the past, but we've expanded on that. So Scotland have an all Scotland DNACPR policy, for instance, and form. So a Scottish patient might come on holiday to Wales, and that form is still very relevant to their care. England and Northern Ireland have their DNACPR forms, also have respect form. And I repeat that a respect form is not a DNACPR form, but has DNACPR information on it. So bottom of the first page has a tick box on DNACPR. Research UK are at pains to stress that it is not a DNACPR form, but rather an advanced care plan. And these forms form part of the patient's record and are to be considered when you're weighing up what to do. So in the same way that if you had a letter from a Scottish oncologist stating that the patient has an advanced melanoma with spread to the brain and other organs in the body, you would hardly ignore that if that patient came to Wales and required medical attention. So a respect form or all Scotland DNACPR form would form part of that decision-making process and would in fact be very important as well. And then in section 9 of the policy, the update has been on training and education resources. So we've added quite a few of those, including ESR modules. I've recently updated the All Wales DNACPR policy ESR module, for instance. We've got the eALCA learning and the Learning at Wales resources, specifically for those people who can't access ESR modules, for instance. And we've linked to many of these in the policies. And in fact, we sent out these education resources as a letter to all medical, nursing, and allied healthcare professional directors across Wales for dissemination. Whilst our Advancing Future Care Planning Strategy Group cannot mandate these resources, individual LHBs and trusts can mandate them. And some have put this into their action plans on the AMAT audit systems for DNACPR audits and TEP audits. So that may be something that more and more people will now access and do. And here you can see some of the different resources as well. Section 10 gives details on the audit processes, AMAT processes for each local health board and trust, and that audits have to be performed every 2 years, usually coordinated by the resource officer teams and leads in each area. And the audit results are then important and then fed back and actioned at board and trust governance, quality and safety meetings. And in section 10.14, we've talked about individuals' rights to privacy, dignity, cultural beliefs and respect. This was one of the recommendations from the Health Inspectorate Wales report on DNACPR, that culture should really feature in DNACPR discussions. And so we've put a few things in there that we feel are quite relevant to cultural aspects of DNACPR, and you may be interested in seeing that. We also had a very kind agreement and submission from a lady who wrote some poetry about her mother and her time in hospital, and with her permission, we've put that at the end of the All Wales DNACPR policy. If you've gotten to this point of the video, I'd urge you to have a little look at that, because I think it's very important. The reference list has been updated as well, includes a lot of the more recent discussions and reports, including the National Mental Capacity Forum's annual reports and National Nosocomial COVID-19 Programme end of programme report from 2024, for instance. And that leaves me with the final section of this, which is the actual form itself, which we've added to the policy document as well. So this form will be updated. We'll need to talk to the printers and then they will get the process going. We've also updated the patient information leaflet as well. That will go onto the website, but also will be available from the printers. So you have the form here, and the top left section, as you can see here, is a little bit different, because we've stated in that this recommendation is generally valid until end of life. Unless cancelled, see policy in section 7. If not valid until the end of life, if the above statement does not apply and this form is short-term only, please specify a review date. And then the outcome of the review can be added in the box below. Because DNACPR forms have to be quickly read in emergent healthcare situations by paramedics, for instance, who arrive at someone's house who they've never met before, space is always an absolute premium. So we have to get everything onto one page, in a sense. And this is a massive challenge, as you can imagine. But what we sort of recommend is that where there are free text boxes, for instance, that you write a short summary and that you reference the clinical notes, contemporaneous clinical notes. Often what I see is that someone has written, for instance, I've discussed this with the patient and their family in some detail. Please see discussion from the 23rd of October 2024 in contemporaneous patient record, and that's a useful place to then look at further information. At the top, we've said this form must be filed at the front of the patient's healthcare record. Does the patient have capacity to participate in discussions about treatment escalation and CPR? And this is an important addition, basically, because the mental capacity side of things has to be with regard to the individual decision and discussion that has taken place. Has the patient appointed the health and welfare lasting power of attorney to make decisions on their behalf? If yes, they must be consulted. At the top as well, if you've answered no to the first question, does the patient have capacity to participate in discussions about treatment escalation and CPR? If no, reference your written assessment in the health record and consult those close to the patient. And then section 2 has the summary of the main clinical conditions and comorbidities and the reasons why CPR might not work or be inappropriate or not in the patient's best interests. For example, it could state cancer with widespread metastatic disease. In grey, we've written clinical summary. You must fill this in for this form to comply with the All Wales DNACPR policy standards. And then you can select the individual reason or reasons that apply to this individual situation. In 3, we've highlighted the duty to consult. Has a discussion taken place with the patient, yes or no? Please summarize decision below. If not discussed, please record reasons, for example, potential for harm from such a discussion, and also discuss with those close to patient in box 4. And then in gray, it says summary of discussion or attempts to discuss must be filled in to comply with all Wales policy standards. Section 4 has appropriate discussion taking place with those close to the patient, a health and welfare attorney, or an IMCA, independent mental capacity assessor. Please also record unsuccessful attempts to contact these people in the box. And then in gray, it says summary of discussion, i.e. attempts to discuss and how contacted, must be filled in to comply with all Wales policy standards. Section 5, healthcare professional completing this form must inform senior responsible clinician who signs or remotely confirms in section 6. And then in section 6, you have the senior responsible clinician with oversight to sign or remotely confirm the below. SRC ensures that the MDT and others involved in care are made aware of decision and record recipients in section 8. I've included in gray a segment on can include proxy signature if the senior responsible clinician was consulted remotely, but add SRC's registration number above, please. And then section 7 is about a cancellation of such decision. And section 8 is about where the copies of this form have gone to and who they've been shared with as well. The back of the form has a lot of information, including some of the resources, where to find the policy. Many patients will receive this DNACPR form as the original copy and take it home with them, for instance, and then on the back they have access to the policy and they can read the policy if they so wish. That was one of the stipulations from the Tracy report a number of years ago, that patients should have access to the policy document. It also links to resources on advanced care planning and future care planning as well, and also to some of the learning resources and information resources as well, such as videos for patients and videos for healthcare professionals as well. And that's it really. And further parts of the appendix, you have the examples of the DNACPR form audit data collection. But I'll stop the sharing aspect now and come back to the main screen. So I hope this has given a bit of an update and provided you with some useful information about the latest version 5 of the All Wales DNACPR form for 2024. There will be a further update in 2026 when we update the form at that point in time. Hopefully this has been helpful, and please do get in touch if you have any further queries. Bye-bye.